This week, we're going to be discussing high-yield clinical applications of IMRT Part 2 and cover some of the disease sites that we didn't discuss last week. And so the disease sites that we'll be covering for today's lecture include GI, CNS, sarcoma, pediatric, and lymphoma. So to begin with GI, we'll be discussing some non-randomized outcomes for anal cancer, esophageal cancer, and pancreatic cancer. So just a little bit of background. Radiation with concurrent 5-FU and mitomycin C is the standard of care for anal cancer. The treatment results in long-term disease-free survival as well as sphincter preservation. However, we know that there's a lot of toxicity associated with this treatment, and patients tend to experience significant acute GI and GU as well as skin toxicity. Retrospective series suggest acute toxicity is improved with the use of IMRT. This is a trial that I'm sure many of you are familiar with, RTOG 0529. It was a phase 2 trial with patients with anal squamous cell carcinoma, T2 to 4, and any nodal status. And these patients were treated with IMRT and concurrent 5-FU and mitomycin C. The doses for her radiation treatment varied by the stage. So if patients were clinically T2 and 0, they received 42 gray to the elective nodes, 50.4 gray to the anal tumor. And a simultaneous integrated boost technique was used in the treatment of these patients with the IMRT. If patients were T3 to 4 or N0 to N3, they received 45 gray to the elective nodes. And then if their involved nodes were less than 3 centimeters, they received 50.4 gray to the node as well as to the anal mass. And if their nodes were greater than 3 centimeters, they received 54 gray to the node as well as the anal mass. And then the toxicity in this trial was assessed with the CTCAE. In terms of the results, 63 patients were enrolled and 52 patients were able to be evaluated. The median tumor size was 4 centimeters. 54% of patients had stage 2 disease. Stage 3A was seen in 25% and 3B in 21%. About half of patients needed treatment breaks due to toxicity. And then approximately 77% experienced combined grade 2 GI or GU adverse events. 73% experience acute grade 2 or more hematologic toxicity, and 23% experience acute grade 3 skin toxicity. Comparing RTOG 0529 to RTOG 9811. So remember, RTOG 0529 was a phase 2 trial of IMRT patients with anal cancer, whereas 9811 used 3D conformal. As you can see in this table, there wasn't really a statistically significant difference in the grade 2 adverse events. However, when you look at grade 3 toxicities, you can see that for combined GI and GU with the IMRT arm, there was statistically significant less toxicity, and the same went for dermatologic toxicity as well as GI toxicity. So this is a figure demonstrating some comparative plans for anal cancer. On the left is a 3D conformal plan, and on the right is the IMRT plan. For whenever we treat anal cancer with 3D conformal, we have to treat the pelvic nodes as well as the inguinal nodes. So as you can imagine, with 3D conformal, the fields are quite large. And so with IMRT, we are better able to spare the bowel as well as the bladder, resulting in less toxicity for these patients. And so this is another comparative plan with the sagittal view. And on my left is the 3D conformal plan, and on the right is the IMRT plan. In the image on the right, you can notice how much more conformal the IMRT plan is and how much more bowel sparing that we are getting with this plan. All right. So moving on to our next GI topic, which is esophageal cancer. So radiation therapy for esophageal cancer carries the risk of pneumonitis and cardiac toxicity. Dosimetric studies have demonstrated improved dose to organs. So there's a published Moffitt Cancer Center experience, which is a good reference. And it was a retrospective review of patients with esophageal cancer treated with 3D conformal and IMRT. Concurrent chemo was given at the discretion of the treating provider. So the initial volume for the esophageal tumors was 45 gray, and the boost to the gross disease was 50 to 60 gray. In terms of the results, 232 patients were evaluated, and there were 138 patients treated with IMRT and 94 patients treated with 3D conformal. The median follow-up for all patients was 18.5 months, and the overall grade 3 toxicity was 24.6% in the IMRT arm versus 37.2% in the 3D conformal arm, which was statistically significant. There was also a statistically significant difference in the mean weight loss, which was 6.1% in the IMRT arm versus 7.4% in the 3D conformal arm. So these are some comparative plans, and on up top is the 3D conformal plan, and on the bottom, letters C and D represent the IMRT plan. As you are probably familiar with, whenever we are treating esophageal cancer, in general, our fields and our volumes are quite large, because generally we start with a gross tumor volume for the esophagus and then expand that, 4 centimeters superiorly and inferiorly. And so generally, there's a decent enough chance that quite a bit of the lung volume and the heart volume can be affected by these tumors. And as you can see, when you compare and contrast for the 3D conformal versus the IMRT plan, there is less cardiac dose, so more cardiac sparing, as you can see here. And then in addition, the lung volume gets less at the high dose and more low dose of the radiation. And then here's another image, axial image, demonstrating the same difference between the lung and the cardiac doses for the 3D conformal and the IMRT plans for esophageal cancer. Moving to our last topic in GI, which is pancreatic cancer. So a little bit of background. So treatment of pancreatic cancer with radiation is quite limited by the critical structures that are adjacent in the treatment field. And there was a systematic review that was performed that showed 3D conformal versus IMRT, which demonstrated significant reduced toxicity for nausea, vomiting, diarrhea, and late GI toxicity with the use of IMRT. Memorial Sloan Kettering also did a retrospective review looking at this, and they included patients with locally advanced unresectable pancreatic cancer undergoing IMRT or 3D conformal, and acute GI and hematologic toxicity were evaluated. In terms of the results, 205 patients were identified. 79% were had tumors in the head of the pancreas, and 21% in the body and the tail. 76% of these patients received induction chemotherapy, and all patients received concurrent radiosensitizing chemotherapy. In terms of the median follow-up, it was 22 months. The median dose was 56 gray for the IMRT arm and 50.4 gray for the 3D conformal arm. 34% of patients were treated with 3D conformal experienced grade 2 or more GI toxicity, compared to about only half, 16% of the patients treated with IMRT. There was no significant difference in hematologic toxicity, and there was no significant difference in hospitalizations. And so here are some comparative plans. Treating a pancreatic cancers is always pretty complicated because duodenum is very close by, and there's often a lot of small bowel in the field. But with IMRT, we are able to minimize the dose to the bowel and get better dose distributions, which in turn can help reduce toxicity during treatment. Before I move on to the next topic, are there any questions related to GI malignancies?
Yeah, there were a few questions. The first was, do you consider dose escalation to primary anal cancer up to 59.4 or more gray?
So that is potentially an option, especially if the tumor doesn't have good response during treatment. My experience with anal cancers, a lot of the patients I've treated tend to have pretty complete responses even midway through the treatment course, where it's not necessarily needed to give a dose escalation, but definitely after 45 gray, if you do have residual tumor, you can consider doing an additional boost.
Okay. Thank you. Do you have any considerations for ITV margins for esophageal cancer?
So for esophageal cancer, it depends. Like at the center where I'm at, I practice in the community, and so we don't have 4D CT capabilities. Except I do have 4D cone beam CT, which is what I use for my lung SBRTs in some cases to assess motion. So given the limitations, I use the standard the RTOG expansions, and I do obtain a daily cone beam CT on all of my patients. And I treat with them with free breathing, and it seems like the volume, because you use such large expansions. I don't think an ITV makes too much of a difference when treating these patients, because in general the volumes are so large and comprehensive. But if you do have the technology available, you can definitely use 4D CT and see and get a better idea of organ motion and everything. But just given the standard protocols right now, I'm not too worried about missing the target, especially since I do obtain cone beam CT before I treat every patient.
Thank you. There's two more questions. I'm going to lump them together. Can you comment on the spillage of doses in esophageal cancer for IMRT and the selection of beam energy, such as 10 or 15 MV?
Okay. So for esophageal cancer, usually all of my patients we treat with 6 MV because I have 6 MV and 50, it depends on your machine capabilities, which energies you have available. But my machine here, I have an Electris Energy machine where I'm at, and so we have 6 MV and 15 MV. And so I do VMAT for all my patients with 6 MV for esophageal cancer. And what was part 2 of the question? Sorry.
Commenting on the dose spillage.
So in IMRT in general, you are able to minimize how much of the high dose goes to the lung as well as the heart. However, there is a chance that you might potentially get more areas, given the nature of using multiple beams and VMAT with arc therapy, that you could get more low dose spillage to the lungs as well as the heart. And so these are things that are taken into consideration, but just based on the nature of the esophageal tumors that I've been treating in my practice, most of them tend to be pretty advanced. And overall, VMAT is like the best modality in even to get me the highest dose to the most conformal dose to the tumor, but the least dose to the lungs and the heart. But with the advent of more beams, there's always a trade-off with more low dose. But in my experience, I haven't seen it contributing to any increased toxicity for my patients.
Okay, thank you. And then just for the high energy question, just to make it maybe a little more clear, from my understanding, the lower energy 6MV is usually preferable, always preferable for IMRT and VMAT. Well, I'd say in like 99% of cases. Do you have any comments on what would prevent you from using a higher energy, or when any specific situation where it might be preferable?
So there's always a fear of potential neutron contamination, and so that's why we prefer to use the 6 MV over a higher energy for these cases with IMRT and VMAT. Where I did my residency training at the University of Miami, and what was interesting there, the standard was we actually used 15 MV to treat all of our prostate cancer cases with VMAT, but that was just an institutional preference. But in general, in my practice, pretty much with IMRT, unless for some odd reason we're not able to get a good plan, or the hot or something, or through the roof or something, we tend to stick with 6 MV.
Great, thank you.
So moving on to the next section, which is CNS. So we will be discussing non-randomized outcomes for malignant glioma, meningioma, and chordoma. So to start off with malignant glioma, a little bit of brief background. So patients with primary central nervous system tumors are at risk for late neurocognitive, endocrine, vision, and hearing deficits. I know more recently in the past few years, there's been a lot of genetic analysis being done on these patients. And what we've noted is that, some patients with more favorable, like MGMT methylations, IDH1 mutations, tend to live a lot longer. So even for malignant glioma, depending on if they have a more favorable genetic mutation compared to other patients, they could have a longer, more favorable prognosis and a longer survival. So toxicity is an important consideration. IMRT may reduce the normal structures and improve target coverage compared to 3D conformal. So there was a Bangalore experience that was published. And so they looked at 50 patients treated with malignant glioma who had 3D conformal, and then they did a comparative dosimetric evaluation with IMRT. And what they noted was that IMRT did improve the target conformality and reduce dose to normal structures, including the brainstem, chiasm, ipsilateral and contralateral optic nerve, and then the hippocampus. Moving on to the next tumor site, which is meningiomas. So we all know that radiation therapy is an effective primary treatment for meningiomas. However, these patients with meningiomas can live for, decades on end. And so they're definitely at risk for late neurocognitive and endocrine toxicities. So there was a retrospective review done at Methodist and Baylor Hospital in Houston, where they looked at patients with meningioma treated with IMRT. The total prescribed dose ranged from 40 to 56 gray, and the median was 50.4 gray. The toxicity was graded using the RTOG acute and late morbidity criteria. In terms of the results, 51 patients were able to be evaluated. The median follow-up was 30 months. The 5-year cumulative local control was 93%. The 5-year progression-free survival was 88%, and the 5-year overall survival was 89%. The most common acute toxicity was mild headache. Only 1 patient had grade 3 or higher acute toxicity of any kind, and no patients had late eye toxicity. There were 2 patients that had grade 3 or higher late CNS toxicity, and so personality changes and memory loss with subacute edema were surrounding the target volume, and was one of the grade 3 toxicities, and also brainstem necrosis after a max dose to the brainstem of 55.6 gray to 4.74 cc's. Okay. And then our last CNS topic is chordoma. So chordomas and chondrosarcomas of the skull base are treated with surgical debulking. Often residual tumor is left due to the proximity to critical organs. Radiation therapy to low doses does not adequately control gross disease, And so IMRT allows us to escalate the dose as well as minimize dose to the organs at risk, which leads to improved treatment. So there was a Canadian experience where the authors retrospectively reviewed patients treated for skull-based chordoma or chondrosarcoma using IMRT. And there were 24 skull-based chordomas and 18 skull-based chondrosarcomas that were included in this cohort. The median follow-up was 36 months in the chordoma cohort and 67 months in the chondrosarcoma cohort. And then the median IMRT dose to the chondrosarcoma cohort was 70 gray, and to the chordoma cohort was 76 gray and 2 gray per fraction. The 5-year overall survival and local control for the chordoma cohort was 85.6% and 65.3% respectively. And the 5-year overall survival and local control for the chondrosarcoma cohort was 87.8% and 88.1% respectively. In terms of the toxicities, there were 6 patients with 8 radiation-induced late injuries, 8 cases of radiation-induced hearing loss, 1 radiation-induced hypothyroidism, 1 radiation-induced hypopituitarism, 1 radiation-induced vestibular nerve injury, 1 cranial nerve core injury resulting in diplopia, and 1 radiation-induced secondary malignant glioma resulting in death. And then these are just representative IMRT plan. These tumors in general are especially very difficult to treat because they're often, very close to critical structures, including the brainstem. I know in the United States, we tend to refer these patients to proton centers for evaluation because protons could potentially allow for better brainstem sparing. But depending on your, technology and what's available, IMRT is definitely a good option if access to proton therapy is not feasible. Any questions regarding CNS malignancies before I move on to the next section?
No, we don't have any regarding CNS.
And in general, in my own practice for CNS malignancies, I tend to differ and use IMRT and BMAT for pretty much every case because usually most of these tumors are close to critical structures, and the dose distribution with IMRT and BMAT is just so much better. Next, we're going to move on to discuss sarcoma. And we're going to discuss non-randomized outcomes with the Memorial Sloan Kettering experience. Just a little bit of background. So radiation therapy improves local control for soft tissue sarcoma. Previous dosimetric studies demonstrate decreased high dose to the bone and skin using IMRT. Retrospective review of 319 consecutive patients treated with limb-sparing surgery and 3D conformal or IMRT for soft tissue sarcoma of the thigh. And in terms of the results, 319 patients were identified. 44.8% of lesions were greater than 10 cm in size. Conventional external beam radiation was used in 48.3%, and IMRT was used in 51.7%. The median preoperative dose was 50 gray in the IMRT group and 50.4 gray in the 3D conformal group. And the median postoperative dose was 63 gray in the IMRT group and 63 gray in the 3D conformal group. The IMRT group had significantly more close and positive margins, larger PTVs, and high-grade histologies. The median follow-up was 58 months, and then the 5-year local recurrence was 7.6% with IMRT versus 15.1% with 3D conformal, which was statistically significant. And also, there was 39.8% grade 2 or more radiation dermatitis with 3D conformal versus 31.5% with IMRT, which was also statistically significant. And then finally, 14.9% had late grade 2 or more edema with 3D conformal versus 7.9% with the IMRT group. And so these are some comparative plans. And so basically, you can see the bone here. And with IMRT, you're able to get better bone sparing and more conformal dose distribution. And then also, I think one of the differences, specifically in the study that we discussed, why the IMRT group had a better local control compared to the 3D conformal group, because you would imagine it should be the same because you're treating the same, areas, same concept. If anything, and with IMRT, you're treating a less of an area. But potentially with IMRT, we tend to be more particular about getting daily IGRT, which in sarcoma, sometimes their setup can be a little more difficult day to day. And so having IGRT also ensures that the positioning and everything is correct, and at the same time allows us to use smaller margins with IMRT as well. Any questions regarding management of sarcomas before I move on? So next I'm going to briefly discuss some pediatric cancers and discuss non-randomized outcomes regarding low-grade glioma, ependymoma, and medulloblastoma. So just a little bit of background for low-grade glioma. So low-grade glioma is the most common pediatric brain tumor. IMRT may allow for sparing of normal tissues while delivering high dose to the tumor. The optimal margin for target coverage, though, remains unknown. So Methodist Hospital in Houston did a retrospective review of pediatric patients with low-grade glioma treated with IMRT, and a clinical target volume margin of 0.5 to 1 cm or an integrated boost method was used for treatment based on the physician preference. In terms of the results, 39 children with low-grade glioma received IMRT, 48.5% had central tumors, optic pathway, thalamus, hypothalamus, 38.5% had tumors in the posterior fossa involving the cerebellum and the brainstem, and then 12.8% had hemispheric brain tumors, with the median dose was 50.4 gray. In terms of the results, the 5 and 8 year progression-free survival was 78.2%, 17.9% experienced local failure, all in the field, and then the 10-year overall survival was 93.7%. In terms of the toxicity, 1 patient developed moyamoya disease, 10 of 21 patients with endocrine follow-up had dysfunction. There was no blindness due to IMRT. 4 of 15 over 18 years were in college. 1 patient was receiving special education, and 1 had secondary malignancy. Moving on, the next pediatric tumor we're going to discuss is ependymoma. So ependymoma accounts for 7% of all CNS tumors in children. The standard of care treatment is surgery, followed by radiation for grade 2 and 3 disease. IMRT may reduce dose to normal structures, but the effect on local control is unknown. So another study done at Methodist Hospital in Houston looked at 22 children with localized intracranial ependymoma that were treated with the adjuvant IMRT. CTV volume of 1 to 1.5 cm beyond the GTV was used, and the median treatment dose was 50.4 gray. In terms of the results, the 5-year local control was 58.6%. All recurrences were within the high-dose treatment field, and at last follow-up, no patient had developed myelitis, visual loss, brain necrosis, or a secondary malignancy. Additional studies evaluating IMRT and ependymoma demonstrated local control of 88.7% at 7 years. The authors have demonstrated improved cognitive sparing, and the effects on hearing and endocrine function could be predicted by dosimetry. And then moving on to our last pediatric tumor. Medulloblastoma is the most common embryonal tumor of the central nervous system. The treatment includes surgery, radiation, and chemotherapy. A commonly used technique for cranospinal irradiation includes opposed lateral brain and matched posterior spine fields. IMRT results in better target coverage, improved junction homogeneity, and a gain in healthy tissue sparing. And a prospective study was developed to report acute toxicity in patients with medulloblastoma treated with IMRT CSI. There was an experience that was published by the Netherlands and looked at newly diagnosed pediatric patients getting IMRT CSI. A dose of 23.4 gray to 36 gray was prescribed to the craniospinal axis. A boost to the primary tumor bed of 54 gray or 55.8 gray, and metastasis to 39.6 gray and 55.8 gray was delivered as indicated. Weekly vincristine and adjuvant chemotherapy were delivered, and toxicity was evaluated using the CTCAE. 15 consecutive patients were evaluated. Within 72 hours from treatment, 66% experienced vomiting and 46% experienced headache. During week 3, 33% and 40% experienced constipation or abdominal pain or cramping, but only in a subset of those receiving vincristine. And at week 6, 73% developed erythema of the cranial skin. In addition, for medulloblastoma, there's the incidence of grade 3 or 4 ototoxicity may be as high as 64% in patients with medulloblastoma treated with conventional CSI. So at Methodist Hospital in Houston, they had patients with medulloblastoma have an audiometric evaluation before RT and during follow-up. And the craniospinal dose was 18 to 36 gray with a tumor bed boost of 54 to 55 gray. The mean dose to the cochlea was higher in high risk than standard risk patients, obviously because they are getting more dose overall. The median audiogram follow-up was 41 months from the initiation of RT. 25% did not have hearing loss in either ear, and grade 3 or 4 ototoxicity was found in 25%, lower than reported using conventional CSI. And so these are some comparative plans for CSI using 3D conformal and IMRT. And as you can see with the IMRT, you do have a lot more sparing of the thorax, abdomen, and the pelvis compared to the 3D conformal plan. Any questions regarding pediatric cancers and the use of IMRT before I move on to the next section?
Yeah, so there are a few questions, quite a few. Let's see. This one, I'm not sure it's specific to pediatric, but considering responsive chordoma to radiation therapy, can you comment on dose escalation and share experience that you might have?
So chordomas in general, like I said, are pretty rare. I just have a LINAC at my center, so I don't tend to treat a lot of these because in the Philadelphia area, we tend to refer these patients to Penn where they have the proton center. In general, these are tough tumors to get a control of. And so, with a combination of surgical resection and radiation, those are our best options. And then in general, from my knowledge, like I personally, I don't have that much experience treating chordomas, but just from what I'm familiar with is with protons, we tend to be able to get the best dose escalation to these tumors while being able to spare dose to the brainstem, which are usually adjacent to.
Thank you. The next question is, in low-grade glioma, does the molecular marker affect the dose selection?
So in general, the low glioma doses are about 50.4 gray. And to my knowledge, I don't treat pediatric cancers either. So that's one caveat. But to my knowledge, I don't think it's impacting dose selection yet. But I know the genetic markers are something that's, recently come about, in the past 5 years or so. And as they provide more information, they may potentially have an impact on how we go about dosing these patients and managing them.
So with respect to that question, how do you choose between 50 and 54 gray?
So like I said, I don't treat too many of these patients, but it also depends on like where it's located, what it's adjacent to. Like if you're trying to meet, like if it's something that's more closer to the optic structures or the brainstem, you might be a little more conservative in your approach. So I think there's a little bit of clinical judgment involved and what you can safely take the dose to as well.
Okay, let's see. There's still quite a few. What dose constraints should we consider for structures like the hippocampus, temporal lobe, hypophyseal seal, pituitary axis?
So the pituitary, I try to do a mean of 30. Hippocampus, I mean, it's all kind of relative to what you're treating. If it's something that's directly adjacent to it, you're not necessarily going to be able to get it as low. But the hippocampus in general, when I'm doing CNS cases, like I only contour it if it's something that's adjacent, if it's like a glioma, a tumor of that sort, or I only contour it if it's something that's adjacent or within the vicinity. If you're treating something that's far away, and with IMRT and a conformal plan, you're virtually not going to get much of any dose to the hippocampus. So it all depends on what you're trying to do. But at the end of the day, if you have a tumor that's next to the hippocampus, it's more important to treat the tumor than to worry about trying to spare the hippocampus. And so that's something else to keep in mind because I would never underdose the tumor in an effort to preserve the hippocampus because getting tumor control is the most important thing in this type of scenario.
Thank you. Still talking about OARs, I guess. How would you balance like lens dose for targets near the cribriform plate? Is there any special considerations for that?
So the thing about lens doses is like when you get radiation to the lenses, it predisposes to getting cataract formation, sooner than later. But at the same time, depending on what I'm treating, if it is something that's closer to the lens and if I can't spare the dose as much, I'm not as worried about it because in the future, if they need cataract surgery, it's a fixable problem.
Right.
So that depending on, whereas like if I'm treating something and it's adjacent to the optic nerve, if the radiation damages the optic nerve, then there's really not anything we can do for that. So I'm much more conservative in that situation because vision is very important to quality of life, and preserving that is also a goal.
Okay. In that same realm, can you comment on PRVs for the optic structures in the brainstem and what sizes you typically see in your clinic or what definitions you have for your PRVs?
So this only comes into account when like I'm treating something that's pretty adjacent. And so this usually at this point in time is when I have a conversation with my dosimetrist, and depending on what the tumor looks like, where exactly it falls, how much room we have, because like it's like sometimes if you're treating a tumor and it's only like say less than 5 millimeters away from the optic nerve, well, it's almost impossible unless you plan on underdosing the tumor. Sometimes especially with VMAT, I might do some dose painting. Like if it's close to the optic nerve, go at a slightly lower dose just to the tumor that's adjacent to it so that I can preserve vision at the same time, but still get as high dose as possible to the area. And then the area that has, that's further away, take it to a slightly higher dose. So it just kind of depends on the scenario. But usually I think as a rule of thumb, you need at least, 5 millimeters to a centimeter for appropriate dose fall off. And sometimes depending on the scenario, if the tumor is so close to critical structures, even if you have a PRV, it's not necessarily attainable. But that's in that type of scenario, I would consider doing some type of dose painting and then try to escalate what I can to that highest dose safely.
Okay, thank you. For structures like the internal ear and cochlea, as the OAR, similar to the lens dose, I think that those are more permanent changes than cataracts? Do you have special considerations for those structures?
So the cochlea can usually tolerate quite a bit. And so depending on the scenario, like if I'm treating something in the posterior fossa, if if the PTV goes into the cochlea, but there's still a little bit of room to spare, I might potentially consider trimming my PTV just a little bit to improve the follow-up of the dose for the cochlea. So there's different things you can kind of tweak depending on what the scenario is. But usually like you want a cochlea, a mean less than 30. Granted, especially when you're doing like head and neck cases, for instance, where you go to quite a high dose overall for concurrent chemo RT, and you might give concurrent cisplatin. That makes the situation a little complicated. So you want to go as low as you can potentially get it. And at least with my VMAT plans, we are able to meet the constraints, generally shoot for like a mean of less than 20, though if we can get it a mean less, but depending on the scenario, I might have to accept a little more.
Okay, thank you. The last two questions are related to CSI, so I'll ask them both. The first question is, how are you able to cover the entire spinal curvature using IMRT? And then what are the considerations in VMAT CSI and how is that different from IMRT?
Okay. So like I told you, I actually don't treat pediatric cancers. I only treat adult patients. So IMRT, CSI is something that I've read about, but I've never actually myself seen it in practice. Usually pediatric care in the US, it's very specialized and tend to be done at, more higher volume centers. At the same time, for CSI, a lot of centers also do protons, and most of the larger pediatric programs have access to protons. So unfortunately, I can't comment too much on the technicalities of that because I myself don't have personal experience with that.
Okay, thank you. Thanks for taking the time to answer those questions. We can visit other questions at the end of the talk.
So the last topic that we're going to be discussing is lymphoma, and we'll be discussing non-randomized evidence for Hodgkin's lymphoma. So a little bit of background. So Hodgkin's lymphoma has a high rate of long-term survival. The patients are often young and at a risk of late toxicity from therapies, including chemotherapy and radiation. However, IMRT delivered by a butterfly technique beam arrangement might potentially reduce the dose to critical structures compared to traditional APPA techniques. And so at MD Anderson, they looked at a study where they had 9 female patients with early stage Hodgkin's lymphoma who were retrospectively reviewed, and then comparative IMRT plans were generated for all the patients using a butterfly technique, where they used 5 to 7 total beams restricted to anterior and posteriorly oblique beam entry angles. And then the patients were treated to 30.6 gray. All of the plans had acceptable target coverage. However, IMRT led to decreases in the breast V30, V25, and V5, which was all statistically significant. IMRT also led to a decreased dose in the spinal cord, which was statistically significant, as well as a decreased mean dose to the heart and its substructures, which was also statistically significant. And then the APPA consistently also led to more hotspots in the field. And so this is a figure that shows the comparative plans for 3D conformal up top and then IMRT down below. And as you can see with the IMRT plan, it's much more conformal and you get a lot less of the full dose to the heart and spinal cord as well as the lungs. So in conclusion, randomized data supports the use of IMRT for head and neck cancers, gynecologic cancers, prostate cancer, anal cancer, and breast cancer. However, there's numerous serious reports of excellent outcomes with IMRT for other disease sites, including CNS disease, sarcomas, GI malignancies, lymphomas, lung cancers, and pediatric tumors. And then IMRT is definitely a great modality whenever there are organ at-risk constraints that are being exceeded with conventional techniques. Just some resources I wanted to bring to your attention. So the RTOG has some excellent contouring atlases. Also, one of my favorite resources to use when I'm doing cases is eContour. This is a completely free resource. And pretty much it shows it has a whole bunch of different cases and all disease sites, and it goes by slice by slice. It has the entire CT scan with the entire plan and all the contours to kind of give you some tips on how to contour these cases. And it's especially helpful for the IMRT cases. Any questions?
Yeah, so we have a list of questions. We'll stick with lymphoma for a second. Are there any evidence for secondary cancers when treating with IMRT? And then that question, I guess, extends to every site, if you can comment on that.
So radiation in general, whether it's photons, whether it's 3D conformal, IMRT, or even protons, if you're giving radiation to a site, especially in the pediatric patient cohort who's going to live for years on end, there's always a chance of a potential secondary malignancy happening in the field. I guess what the question is, it's a little bit of depending, for Hodgkin's lymphoma, we're especially for females, we are more vigilant after they complete their therapy to follow them at earlier ages because they are more prone to developing breast cancers. compared to someone who's never had radiation. So there's a chance, like if you do IMRT, and even particularly if you do like VMAT to treat Hodgkin's lymphoma, you could potentially get more like low dose radiation to the breast, which could contribute to the risk for developing breast cancer. But at the same time, if you're doing APPA, you're still going to get some dose to the breast tissue no matter what as well. And in the butterfly technique that I presented, it seemed like overall the way they kind of carved out that area, that they weren't getting as much. So it's just something to take into consideration. But I think especially with pediatric patients, any patients that are especially younger that are getting radiation have a risk, and whatever modality that you use to treat them isn't necessarily going to change that risk that much.
Okay, thanks. For sarcomas, for post-op sarcomas where joints and bones are affected due to surgical contamination, do we consider two-phased volumes? Specifically, they asked about 50 gray followed by 66. And what are the margins for the tumor bed in these patients for higher dose?
So in my practice and in general in the United States, we favor doing preoperative radiation for sarcoma in general because our treatment volumes are a lot smaller. Whenever you're doing postoperative radiation, you have to treat the entire surgical bed, which is obviously a lot larger than the initial tumor itself. And so, but in general, I do try to, the few postoperative cases that I have gotten, because we assume from the staging workup that for them to not be as aggressive with tumors, the volumes, I believe they're like 4 centimeters inferiorly. I usually follow a protocol when I do it. And then I do cone down and try to take that to 66 gray.
Okay, do you have a comment on what size margins you're using?
Like I said, I don't tend to do many of these, but I think it's about 3 to 4 centimeters, but in general, superiorly and inferiorly. But then you have to be respective of like the muscle plane. So whenever you do contour these sarcoma cases, you have to look at it in your coronal and sagittal views also of the limb that you're treating, because you know that the tumor is not going to extend into a completely different compartment. So if the tumor is located more anteriorly, you know that if you do the expansions and then your CTV expansions are going more into the posterior component, you need to shave it off, because you know that realistically, like the tumor itself is confined to the compartment. So these considerations are also kind of come into play. In general, like 4 cm stupid, but I adjust for the anatomical limitations.
Okay, thank you. Sticking with sarcomas, can you comment a little bit about skin sparing in pre-op sarcoma patients?
So I don't we have a constraint for the skin, which I can't remember off the top of my head for sarcoma cases. But in general, are you talking about skin sparing in terms of a surgeon wanting to do flap reconstruction? Is that the question?
That's not specified.
I think that might be what they're getting. Yeah. But basically, it's always good to have a conversation before you start the radiation treatment for a sarcoma patient with your surgeon, to kind of ask them exactly how they'll be going about doing the surgery. Sometimes if they remove a tumor, there could be such a big functional defect that they might need to move a flap over of the skin to close the wound. So it's always good to just have a conversation with the surgeon. And if it's feasible, I might contour like an avoidance area if the surgeon kind of indicates to me that this is likely where they might be pulling the flap to, and try to give it as less dose as that I potentially can to, potentially help reduce the risk of any complications postoperatively occurring after they do the flap reconstruction.
Awesome. We'll transition over to CNS. What dose do you consider for low-grade glioma in the presence of, STR? I'm not familiar with that.
Oh, is it subtotal resection? Okay, so the doses in general, range from approximately 50 to 60 gray. And so like I said, it also depends for glioma. There's just so many considerations to take into account regarding in terms of where it's located, which critical structures it's adjacent to. And so depending on, there's certain like priorities for organs at risk, like the optic structure and like the brainstem, where if they do get radiation toxicity, it's irreversible, and we don't have a way to, potentially mitigate the toxicity in the future by any intervention. And so those sometimes would take priority. But like I said, whereas if it's something that's more where I get more dose to the lens, I'm not as worried about, because we can, it's a fixable problem with surgery. So a lot of dose considerations, we might have hard, fast like guidelines in the protocols, which is generally I use as a rule of thumb. But depending on where the tumor is located, that might limit my ability to take it completely to the recommended dose, depending on the clinical scenario.
Okay, whether the patient is symptomatic or asymptomatic, how does that play into your considerations?
Well, symptomatic, I'm assuming they mean if they have like headaches and seizures and those types of symptoms. If they're having having like headaches and if they're having, generally these patients, they might have been on Decadron at some point, and then if they've been having seizures and they're on the appropriate medications for seizure prophylaxis. But if they're symptomatic, that doesn't necessarily change what my dose will be.
Okay, awesome. Do you have any, or would you like to comment on any experience of doing reirradiation in brain tumors?
So reirradiation. So my own personal experience is more for like whole brain reirradiation. After if I've treated them with whole brain before and then they recur again, and in that scenario, I would do like 25 gray and 10 fractions. Reirradiation for like glioma, it's pretty tricky because you've already maxed out on quite a bit of the dose. So a lot of times, like for malignant glioma, what we would consider is potentially, additional chemotherapy. I know tumor treating fields for malignant glioma is something that's gained a lot of ground in the past 5 years or so in the United States. And so in the recurrent setting, that could be an adjunct treatment as well. But it also depends like on the location of the tumor, where it's located. If it's like a focal, tiny little recurrence versus a much larger one, those are all considerations to kind of be taken into account.
Awesome. The last question that I have that's been posted so far moves on to esophageal cancer. Considering locally advanced esophageal diseases, can you comment on balancing doses between lung and heart, and what doses would be acceptable for those OARs?
So in general, the NCCN guidelines that really everybody hopefully should be able to have access to, and basically for those of you who might not be familiar with the NCCN, it's their national cancer guidelines that are used in the United States. And you can create a free account and get access to all the information there. But the NCCN specifically for esophageal cancer, they do an extremely good job of listing a whole bunch of different constraints for lung, for heart, etc. And those are the constraints that I reference when I do my planning. In general, for esophageal cancer, we like to keep the V20 less than 20%. We try to keep the mean heart dose less than 20. There's the V40. There's different considerations, but in terms of what I reference when I do these cases is the NCCN guidelines, and they list out a whole bunch of constraints, which I think are an excellent guideline to use whenever you are doing IMRT for these cases.
Thank you for pointing out that reference and answering all those questions, and for giving a great presentation.